Thank you so much for inviting us here today to present this research on COVID-19 vaccination and long COVID in adolescents, and I'm happy to present on behalf of multiple authors who are in the room today. So if we try and think about vaccination and long COVID, there's a number of places where potentially it could target. So the first is obviously preventing infection altogether. We know, though, that COVID vaccine is not a sterilizing vaccine, meaning that while it can prevent some infection, particularly with vaccination closer to the time of seeing a virus, it doesn't prevent infection necessarily altogether. Secondly, it could decrease the severity of acute infection, although, again, we know that you can get long COVID depending, whether it's severe or mild disease. It also could potentially mitigate some longer-term pathophysiologic response to infection. And so when we're sort of beginning to think about this study, we're really trying to actually, with RECOVER, trying to focus on those last two. So what do we know? So studies have generally shown vaccination to be protective against long COVID in adults, which you heard yesterday. And there have also been some EHR studies that have looked at vaccination against long COVID in children and adolescents, particularly electronic health record studies. But only one analyzed adolescents independently, and that was the RECOVER EHR study. There's also a post-COVID clinic in Italy, which has done wonderful work, which did see a protective effect against long COVID, but they broadly define long COVID as at least one persistent symptom. And we know from our RECOVER cohort that actually is quite common. Maybe about 40% of our patients have at least one symptom. And there was another meta-analysis which then showed no effect looking at children and adolescents. So we were interested in looking across RECOVER, which is a large, diverse community cohort that's drawn not only from medical settings to see if we see an effect. So we want to assess the impact of COVID-19 vaccination prior to SARS-CoV-2 infection on preventing long COVID among adolescents with history of SARS-CoV-2 infection of those who are infected in the NIH RECOVER study. So just very briefly about RECOVER, which you heard about yesterday. We have our main cohort, which are people who are recruited de novo into RECOVER. They're 0 to 25 years. We have those who are acute infected, post-acute, and uninfected, and caregivers. Then there's the ABCD cohort, which is the NIH-funded adolescent brain cognitive development cohort, in which a number of people cross-enrolled into RECOVER. They also have post-acute, uninfected, and caregivers. We also have the congenital cohort and MIS-C cohort, and we're not including those in these analyses. For RECOVER Pediatrics, we have a number of enrolling sites across the country. So to be included in this analysis, we focus on adolescents, so 12 to 17 years, who were enrolled either in that main cohort or in ABCD. They had to have had a history of SARS-CoV-2 infection by the time they were enrolled into RECOVER. And that infection had to have occurred at least 90 days prior for a long COVID research index. And they couldn't have had a recent infection, meaning within the last 30 days. And we excluded those who had MIS-C at enrollment because it really is a different kind of disease. For our exposure, first looking at those who are unvaccinated. So if we're kind of starting at the time point of their first SARS-CoV-2 infection, looking backwards, they had to have had no doses of vaccine. And for our vaccinated, they had to have received within 6 months prior to that first infection, but not within 14 days, so that we know they had some immunity built up from the vaccine. And for our study endpoints, our first primary endpoint was presence of long COVID at their enrollment visit. This was based on the long COVID research index, which you heard about yesterday, and I'll talk about a little bit in the next slide. And then our secondary endpoint was on severe long COVID, which was defined based on the symptom profile with the highest symptom burden, as well as the worst quality of life. So for our research index for adolescents, this is is calculated, and if you basically get a sum of scores, and if you at least reach threshold of 5, then we consider you to be long COVID probable. As Tony mentioned yesterday, those who, even though this is sort of a kind of posse symptoms, they actually reflect a number. When we look at those who meet threshold, we really are capturing like the full range of symptoms that you would see with those with long COVID. For analysis, unvaxxed participants were matched to 1 or 2 vaccinated participants, and that was based on sex assigned at birth. That was exact matching. Date of first infection within a 45-day window, and date of enrollment within 90 days. Just focus on that middle one for a second. It was, I think, important to us because vaccine rolled out later for children and adolescents. We needed to make sure that we were sort of matching infections at the right time, which means that this population is really drawn only from those within their first infection at the time vaccine was available, because we didn't want to introduce bias in the study by comparing those who were potentially unvaccinated and infected before vaccine was available. We then estimated the risk ratio for association between vaccination and long COVID, and we did a sensitivity analysis, which that model did adjust for the SARS-CoV-2 variant, caregiver education, and then residency in a medical underserved area, since those things could both affect vaccination as well as potentially long COVID. Just in terms of our basic demographics, I won't go through all of these, but it was a generally fairly well-matched population. You can see, though, caregiver educational attainment was different between the two because it is correlated with vaccination. Another reason why it was important that we ultimately adjusted for it. And that side note is important, which is that 84% of those who are vaccinated had at least 2 doses in the 18 months prior to their first infection. So again, we're really focusing on at least 1 dose. So what do we find? I'm happy to say that this was just published in Vaccine, so that's the reference if people are interested in looking. And so in those who were vaccinated, 13.3% had long COVID at enrollment, compared to 27% who were not vaccinated. So that gives us a relative risk of 0.64 or a reduction of 36%. When we did that adjustment, our relative risk was 0.74, and that was significantly different. For severe long COVID, there was a difference, but it was much more narrow. So vaccinated, 4.7% had severe long COVID versus 6.1% not vaccinated. And you can see the relative risk in this case is not significant. So in summary, vaccination in the 6 months prior to first infection did reduce the risk of long COVID by 36%. And it does highlight that even if the vaccine is not preventing infection, because again, we know it does prevent infection in many cases, but not all cases, and really most ones are proximal to when you were vaccinated, that there is still a protective effect of vaccination. That actually makes COVID-19 vaccine relatively unique in having this sort of secondary prevention effect on progression to a chronic condition despite infection. So if you think about most of the vaccines we give, we're really trying to prevent infection as kind of the primary action. In this case, even if we're not preventing infection, we are actually preventing some of long COVID. This may be a conservative estimate for a number of reasons, just to highlight some of them. Our long COVID research index is focused on long COVID present at enrollment, so it doesn't consider long COVID that may be in remission. And that might partially explain why in the EHR cohort paper I mentioned, that they had a higher vaccine effectiveness that they noticed. Adolescents could also have subclinical long COVID that didn't meet the research index definition. Again, this is a research index definition. We were actually really focusing on specificity. And so, again, there are people who clinically may have long COVID, in this case, would not have been captured. And then also vaccination, we aren't capturing vaccination that reduces infection. That was sort of the point of the study. And so, obviously, if you're looking at the totality of the way that vaccines can prevent long COVID, that's a piece of it as well. However, given the profound impact that long COVID can have on the health, well-being, and educational attainment of adolescents, as we have heard, the lack of treatments for long COVID, particularly in children, we do think that these findings do support vaccination as an important and effective prevention strategy. We want to acknowledge everybody who has contributed to Recover. It really does take a village. Most importantly, our participants and their families who really are so generous with their time with us in this study, as well as all of our study sites, our funders, and really all the people who are involved in Recover. Thank you.